Welcome back to the American College of Surgeons Bulletin Brief from the Frontline Surgeons' Voices. With me today are two dear friends, two SAGE's past presidents, Doctors Rick Greene and George Berci, both luminaries in endoscopic surgery for the last several decades. They recently authored a very interesting book, which they were kind enough to let me see, No Stone Unturned, that we're going to discuss today. Dr. Berci is an emeritus surgeon at Cedars-Sinai in Los Angeles, where he's also renowned as an educator, researcher, and innovator. Dr. Greene, in addition to his functions at SAGES, also served as second vice president of the American College of Surgeons, chair of the Commission on Cancer for the American College of Surgeons, the editor-in-chief of the AJCC staging manual for many years, amongst other functions, and is now at the Levine Cancer Center in North Carolina. Welcome, gentlemen.
Thank you.
So I'd like to start with you, Dr. Berci, if I might. You've had a very long, illustrious career. Your innovations have touched surgeons and patients around the world, and you still find time to be active and tell us what we need to know, not only about the past, but about the future. And reading the book, No Stone Unturned, I must say it was a wonderful transition from what happened in the past to what we need to do in the future. So perhaps you could start out telling us, what was the impetus for writing this book?
I was early stage involved in biliary surgery and surgery in general, not speaking from endoscopy. As you know, if you're talking about a telescope which was reported first in 1875 in Nice with the old little system, the major issue is we didn't get a very good view, was only monocular. I think the major milestone was that I was able, when I immigrated to Australia, I made a couple of trips to London and found a physicist, Hopkins, and this changed completely endoscopy, the new vision. This was number one. The second one was illumination, and third one was video. And these three parts I participated. We developed the first miniature video camera in 1962, and this opened up the laparoscopic surgery. That's number one. The other aspect was that I was able to collect data. I traveled an enormous amount and was able to put this together. This book, what was shown in reality, are two books. One is Care. I wrote the book approximately 40 years ago. The book is written in German, 490 pages, and it took me years to translate it. And when I translated it, I was able to reduce the translation to 60 pages. Care, 100 years ago, published 2,000 cholecystectomies. Very important to note in Care's work, who worked in Berlin, that Mayo and Halsted, our two great American surgeons, visited Care to learn more about the surgery. Very important that Care, 100 years ago, recommended to train young surgeons, not only in surgery, but also in anesthesia. Anesthesia didn't exist at that time. This followed up to his magnificent teaching techniques, how to take a history, how to operate, how to measure the time, how to follow up the patient. But I was very intrigued by one, that he had an artist who I built a podium. Again, 100 years ago, the artist was there 6-8 months that he learned the anatomy. And then he made color 3D paintings of the anatomy. And this is a very interesting part that this ages ago, they were very interested in documentation. This gave me a thought how important documentation is. And it's even more dominant today in the area of laparoscopic surgery. This is the first part of the book. And the second one, of course, what is our data about to have 3 decades laparoscopic surgery? And then we mentioned with Greene various areas which are very important today for future analysis and improvements.
Thank you very much. That's and you have a unique perspective that very, very few other surgeons have when you talk about 100 years ago, and also good linkage with the college, with Codman in terms of documentation of data. So perhaps we could go and turn over to Dr. Greene and talk a little bit about how that history and the importance of documentation and the translation from German, how that relates to us today and how you wove that into your book as we look towards the future.
Well, thanks, Steve. You know, it was such an honor and a pleasure when George contacted me and asked me to collaborate on this book with him. We had already collaborated, as you probably know, with George's autobiography, which we entitled The Scope of My Life, and that came out a couple of years ago. So this was really our second collaboration. And as George said, you know, some of the principles that Hans Keir, put forward are as important today as they were in the late 19th century, early 20th century. The other thing we wanted to do with this book was to incorporate the concepts and the ideas of many of our colleagues who were involved early on in laparoscopic cholecystectomy and biliary management using endoscopy. And we were very pleased that about 15 of our colleagues have contributed to this book, given their ideas of where we should be going, where we came from. And as George said, I think one of the overarching principles that we're trying to put forward is that there's so much more that surgeons can be learning. There's so much more that surgeons can be doing in the operating room relative to biliary tract disease. And George, of course, has been the leader of this concept. Unfortunately, many of our academic groups, many of our residency teaching places have gotten away from the concept of doing all the biliary tract surgery. And we've really given up a lot of these ideas to other colleagues in other specialty areas such as gastroenterology. So that was one of the overarching principles also bringing out this book and maybe throwing down the gauntlet for our academic colleagues. And George and I have been involved in academic surgery and teaching of residents for many years because we need to think about the principles that Keir and others brought forward and remember that we take care of the biliary tract as well as any other specialty. And we shouldn't give up. We shouldn't give up our tools as we go forward well into the 21st century.
That's interesting about not giving up tools and about throwing down the gauntlet, because it resounds with me a little bit about why you and a group of others founded SAGES in 1981, when a time when not all surgeons were embracing endoscopy. And I'm wondering if we're not sort of seeing the same pattern again.
Well, I think that's a very prescient concept, and that is true. Even our surgical colleagues in other organizations felt that the gastroenterologists should be the ones who participated in the endoscopy suite and that surgeons should only stay in the operating room. We felt differently. And as you know, growing out of that, not only was flexible endoscopy important in the beginning of an organization such as SAGES, but now all of endoscopy is important in many different specialties. And of course, George has been a leader in all of those. He's brought out instrumentation that's been used in pediatric surgery, that's been used in otolaryngology, that's been used in a number of specialty areas. And so again, following in his footsteps, it was such a pleasure to collaborate on this book.
Yeah, I can well imagine, and I very much enjoyed reading the book, and certainly the scope of my life was powerful in gripping. Anybody who is not familiar with the life of Dr. Berci should absolutely lay hands on that book and read it. So, Dr. Berci, let me turn back to you. And Dr. Greene mentioned your passion for innovation and how many fields you've innovated. So what do you think needs to be done to get all of the surgeons now to embrace these concepts? I mean, are there innovations necessary, or is it a matter of people being aware of the ones there so that, for example, laparoscopic common bile duct exploration is more safely done by more people without relying on ERCP, or whatever the case may be?
I would like to respond only on the biliary surgery, where we had, at the moment, we have 1 million laparoscopic cholecystectomies a year, enormous amount of numbers. Everybody knows since Langbuch and other pioneers described the first experience that approximately 10% of all gallbladder patients have CBD stones. And previously, we performed this with appropriate training in one session. The patient didn't have 2 surgeries. We have plenty of data which shows that we did a good job compared with today. And today we have approximately 100,000 patients who are transferred to another colleague who do a ERCP with 5% pancreatitis. Therefore, I think there are certain changes which has to be reanalyzed. We did it in the past very well. In one sense, it was better for the patient. There is another aspect about the bile duct injuries. We know very well that the introduction of intraoperative cholangiography or intraoperative imaging is crucial to discover complications. These are the major issues which we have to deduct after 3 decades of experience, that we need improvements, and how we can institute the improvements. That's very important. Approximately 10,000 surgeons today performing the procedure. They're doing it somehow and doing it well. We can't have changes introduced in this area. There are many other areas where we need improvement, but there is a chance, if we look into the results and the data published, that we can improve biliary surgery final results if we performing improved training. And this is the surgical residence training. If we have 220 surgical residents, and after 5 years, the resident has done 100 lab choles, it's very easy to introduce 4th or 5th year without changing or interfering with anybody's practice, to do the entire procedure in 1 year with better results. The other aspect which I briefly want to mention is reporting. We have 1 million cases done, very few reports. Therefore, these are the conclusions. The aim is to improve patients' care.
Thanks very much, George. And Rick, if I might just turn back to you as we wrap up, talking about improving outcomes, and the office next door to mine is a dear friend of all 3 of us, Raul Rosenthal, who has shown a lot of potential for fluorescence imaging of the biliary tree. And where do you think that lies now? Is that a standard of care? Is that a still to be proven technology? Is it a nice to have?
Yes, there are certainly many of these new techniques that have come out since intraoperative laparoscopy and intraoperative cholecystectomy was brought forward. And I think they're valuable because they at least indicate where the structures are. I think that's one of the reasons that we want to do these types of studies intraoperatively for safety. My concern a little is that they fall short in actually identifying retained stones and then doing something about the stones. It's like the concept in certainly the colorectal area of doing CT colonography. CT colonography is wonderful, sure. You still have to prep, but you don't have to have a scope in your GI tract. But the point is, if you see something, you still need colonoscopy. And colonoscopy is still the important study, as I think in biliary tract disease, intraoperative cholecystectomy and the management of stones is still important. I don't discredit and don't diminish other techniques. Ultrasound has been used for years, looking for stones as well. These are good techniques that should be used by every surgeon doing biliary tract disease. And I think we need to embrace all of these techniques.
Thanks very much. We'll give each of you a moment just to share any additional thoughts before we close. Maybe we can ask you first, Dr. Greene, and then close with Dr. Berci.
Steve, I want to thank you for highlighting this work. I will mention it was a labor of love to bring out a book during the pandemic. Having both of us on opposite coasts in the United States, working with Zoom calls and dealing with publishers who now not only publish in the United States, but work all around the world with printing of books. It's different. It was a true labor of love, and it was a joy to work with my good friend, George Berci, who I have known for over 40 years. So I want to make sure everybody knows that.
George, we'll leave the last word for you.
Well, to change directions, I have some memory pictures about areas where you are more knowledgeable with colonoscopy. When I started this one, I practically I was number 2. And when we introduced colonoscopy, surgeons were reluctant, because I said I'm doing much faster and better a hernia repair than go there to a different area. But again, with the book, we tried to put a message over from the past and the present. And the major issue is we have enough data to recommend certain improvements for improved patient care.
Fantastic. Well, both of you gentlemen have done a lot to improve patient care and improve outcomes during very long, illustrious careers. It's a pleasure to benefit from your wisdom, as well as the 15 or so illustrious surgeons who authored commentaries in the latter part of the book. So thanks for producing the book. For the rest of us to benefit from the fruits of your Zoom labors. And I look forward to the next project, which I'm sure will be forthcoming.
Thanks, Steve.
Thank you, Steve.
You're welcome. Stay well, gentlemen. Hope to see you in person sometime soon.